Good morning, everyone. This is the Orlando GI Journal Club. This is 7 a.m. April 3rd, 2024. I hope everyone's having a good morning or evening so far. Our first study is by Barbosa et al. It is from the British Journal of Anesthesia. This is comparing Remimazolam versus propofol for sedation in GI endoscopy procedures. This is a systematic review and meta-analysis. Propofol is the most commonly used hypnotic agent during GI endoscopy. Its advantage is that it is short-acting with rapid onset of action and redistribution rate. However, propofol is often associated with adverse events, mainly hypotension and respiratory depression. Remimazolam is a new intravenous benzodiazepine which may offer an advantage over currently available sedatives. It is ultra-fast and its action undergoes metabolism independent of hepatic and renal function and has a favorable safety profile with potential for lower incidence of significant adverse events. So this meta-analysis was to compare the efficacy, safety, and satisfaction-related outcomes between Remimazolam and propofol for sedation for adults in GI endoscopic procedures. This was a systematic review meta-analysis of randomized trials comparing Remimazolam with propofol, and the studies combined the use of these sedatives with short-acting opioids in patients undergoing GI endoscopy. They included trials that reported at least one of the outcomes of interest, and they included 15 randomized trials comprising 4,516 subjects. The primary outcome was the success rate of sedation. In this meta-analysis for the primary outcome of sedation success, they found that propofol was marginally better than Remimazolam, with a risk ratio of 0.99 and confidence interval ranging from 0.98 to 1. When they looked at secondary outcome measures, which included induction time, total sedation time, time to full alertness, adverse events such as respiratory depression, hypotension, bradycardia, satisfaction of patients and endoscopists, they found that Remimazolam resulted in a significantly longer induction time, as you can see here. But Remimazolam had significantly lower rates of respiratory depression, hypotension requiring hypotension requiring treatment, and bradycardia. The limitation of this meta-analysis is that all included studies were conducted in China, which may affect the generalizability of the findings to non-Asian patients, and most patients included in the studies were ASA classes 1 and 2. Most studies also did not evaluate post-operative delirium, which is a known adverse event of benzodiazepines, especially in older patients, and some outcomes of interest had a significant between study heterogeneity. So the take-home point from this systematic review meta-analysis of randomized trials is that there are similar clinical efficacy, with sedation success being marginally better for propofol compared to Remimazolam, but Remimazolam had better safety profile compared with propofol. They also reported similar results in both younger and older patients. Our second study was published by Goldstein et al. In gastroenterology. This is a multi-center randomized trial looking at standard of care versus Octreotide in angiodysplasia-related bleeding. Angiodysplasias are the most common vascular malformations found in the GI tract, especially in elderly patients. The typical clinical picture consists of recurrent overt or occult bleeding episodes resulting in iron deficiency anemia, which is managed usually with iron supplementation and blood transfusions. Endoscopic ablation of angiodysplasias with APC is the treatment of choice. However, efficacy is limited, and rebleeding episodes are encountered in 34% of patients within 2 years after endoscopic therapy. Somatostatin analogues such as octreotide and lanreotide decrease duodenal and splanchnic flow through vasoconstriction, improves platelet aggregation, reduces nutrient and oxygen supply required for angiogenesis, and inhibits vascular endothelial growth factor. Therefore, the aim of this randomized trial was to assess the efficacy of long-acting octreotide in patients with refractory anemia due to bleeding gastrointestinal angiodysplasias. This is a multi-center randomized trial conducted in the Netherlands. They included patients 18 years or over in age who have transfusion-dependent anemia due to angiodysplasia, who had received at least one endoscopic treatment attempt and at least 4 units of blood transfusions in the preceding 1 year. Patients were randomized in a 1-to-1 ratio for 52 weeks to either the long-acting octreotide plus standard of care, which included iron infusion and blood transfusions, versus standard of care alone, which consisted of iron infusions and blood transfusions. The primary outcome was the mean difference in the number of transfusion units, that is, including both packed red cells and iron between octreotide and standard of care groups. They enrolled 31 patients to the octreotide group, 31 patients to the standard of care group. The mean age was 72.5 in the octreotide group, 71.8 years in the standard of care group. If you look at their comorbidities, they were quite significant in both groups, with valvular heart disease being the most common, followed by ischemic heart disease and arrhythmias. Also, when they looked at the number of years with anemia, 7.7 in octreotide, 5.4 years in the standard of care group. The location of the angiodysplasias were in the stomach in 23%, in octreotide 32% in the standard of care groups, small bowel 87% in both octreotide and standard of care, and 45% versus 52% in the octreotide versus standard of care in the colon. Multiple locations of angiodysplasias were found in 42% in octreotide and 55% in the standard of care. The total endoscopic procedures performed in each group was 8 as baseline for both groups, with the interquartile range of 6 to 11. And when they looked at biochemical analysis with hemoglobin at baseline, it was 6.3 in both groups, and ferritin level was 161 in octreotide versus 165 in the standard of care. Now, when looking at the outcome measures, the primary outcome, when they looked at the transfusion units, it was significantly lower in the octreotide group, with median of 11 versus 21.2, with interquartile range in the octreotide group of 5.5 to 16.5, with interquartile range of 15.7 to 26.7 in the standard of care group, with p-value of 0.012. When they looked at the individually packed red cells and intravenous iron transfusions, it was 8.2 packed red cell units in octreotide versus 16.8 in the standard of care. Intravenous iron transfusion was performed 2.8, median of 2.8 versus 4.6 in standard of care. When looking at the endoscopic procedures performed, 0.1 in octreotide versus 0.7 in the standard of care group. And when also looking at healthcare utilization, they found that, again, bleeding episodes were lower in the octreotide compared to standard of care group. Hospital admissions were also lower in the octreotide versus standard of care group, and so was the use of emergency care 0.3 versus 1.6 in the standard of care group. Adverse events were encountered in both groups, 71% in the octreotide group, 68% in the standard of care. When looking at the type of adverse events encountered, drug-related was encountered in 91% of octreotide, gastrointestinal 75%, glucose intolerance in 15%, anemia-related adverse events in 55% for octreotide group. For standard of care, drug-related was accounted in 33%, GI adverse events in 86%, anemia-related 95%. Mortality, unrelated to, in total, occurred in 16% octreotide, 6% in the standard of care. Unrelated octreotide was considered in 4 out of 5 in the octreotide group and 2 out of 2 in the standard of care group. The limitation of this randomized trial is the relative high doses of octreotide we used in the trial, which possibly resulted in more adverse events. Also, the sample size is fairly low at 31 patients in each group. Endoscopic treatment was also more frequently performed in the standard of care group, and 5 patients in the standard of care group, it says, were crossed over to the octreotide group. The take-home point from this randomized trial is that octreotide effectively reduced the transfusion requirement and requirement for endoscopic procedures in patients with angiodysplasia-related anemia. Physicians should consider treatment with octreotide in patients in whom endoscopic treatment is insufficient or unfeasible. Next is a study by Yoshida et al., published in the American Journal of Gastroenterology. This is a randomized trial looking at the additional 30-second observation of right-sided colon for missed polyp detection with texture and color enhancement imaging compared with narrow band imaging. The polyp miss rate using white light imaging ranges from 20 to 27%. Meta-analysis has shown that narrowband imaging is associated with higher adenoma detection rate when used under good bowel preparation. Authors have shown in a prior study that examination of the right colon for an additional 30 seconds using narrowband imaging after initial white light examination increased adenoma detection rate by 3.9%. The TXI imaging, known as texture and color enhanced imaging, uses 5 colors of light emitting diodes. It was launched in 2020 in a new processor system by Olympus, which was designed to improve lesion visibility. The aim of this study was to evaluate and compare efficacy of additional 30-second observation in the right-sided colon using TXI versus MBI for detection of missed polyps. This was a multi-center, non-inferiority randomized trial conducted in Japan. They included all patients 40 years or over undergoing colonoscopy for GI symptoms, or screening colonoscopies, surveillance, and positive fecal occult blood. Cecum and the ascending colon were observed with a white light, and then the scope was reinserted into the cecum from the hepatic flexure, and the right-sided colon was observed for an additional 30 seconds, either using TXI or using MBI, depending on the randomization. Non-inferiority margin was set at 10%. The primary outcome measure was to compare the mean number of adenomas and cell-serrated lesions per patient in second observation between the TXI and the MBI group. They enrolled 177 patients to the TXI group, 181 patients to the MBI group. The mean age in both groups was 68.3 versus 68.4 in TXI and MBI respectively. The expert to non-expert ratio was 80 to 20% in TXI, 77% to 23% in the MBI group. Anticoagulation use was seen in 5% of both groups. Antiplatelet agents were used in 18.1% of the patients in the TXI group, 14.9% in the MBI group. The insertion time was 5.7 minutes in both groups, and valve preparation was considered excellent. And good versus a fair and poor in 117 patients in the TXI group, 60 patients in the with the fair poor PAL prep in TXI group, 135 patients in the MBI group had excellent and good prep, and 46 patients had fair or poor prep. The total procedure time for the whole colon, including the insertion, observation, and treatment, was 19.5 minutes in TXI, 20.1 minutes in the MBI group. The main outcome measure was the mean number of adenomas and SSL per patient. And as you can see, this was 0.29 in the TXI group on second observation, and 0.3 polyps in the MBI group on second observation, resulting in p-value of 0.87. And when they looked at the difference for non-inferiority, it was minus 0.01, with p-value of for non-inferiority was 0.02, and therefore TXI was non-inferior to MBI. Also looked at the increase in adenoma detection rate for the right-sided colon. It's 10.2 versus 10.5 in the TXI versus MBI on second look. The increase in adenoma and cis-ulcerated lesion for right-sided colon was 13% in the on second observation with TXI, and 12.7% with MBI on second look. When the authors compared the first observation with first and second observation combined, they found that in the TXI group, the mean number of polyps detected, the mean number of adenomas detected per patient was 0.49, and it was 0.71 for the first and second observation combined, which resulted in p-value of 0.02. Again, this was seen in the MBI group. Also on second, when combining second look with the first look, again, the mean number of adenomas and cis-ulcerated lesions and the mean number of all polyps detected per patient was significantly higher when you combined second look with the first look for both the TXI and the MBI groups. The limitation of this randomized trial is that endoscopists were not blinded and knew the modality of MBI or TXI used in the second examination, and therefore there is a risk of observer bias. The addition of 30-second examination was applied only to the right colon, and the study was conducted in Japan, and therefore this may limit generalizability to other ethnicities. The take-home point from this randomized trial is that the effect of add-on 30-second observation of the right-sided colon using TXI was non-inferior to MBI for polyp detection. Our last study is by Sharma et al. This was published in the Clinical Gastroenterology and Hepatology, and they looked at the use of statins, decreasing the risk of severe liver disease in individuals with non-cirrhotic chronic liver disease. Statins have been shown to inhibit inflammatory pathways, promote endothelial cell function, and reduce hepatic stellate cell activity. And the hypothesis is that statins could attenuate progression of liver fibrosis. Prior clinical and epidemiological studies of patients with non-cirrhotic chronic liver disease suggest that statins may have beneficial effects on progression to cirrhosis, hepatocellular carcinoma, and mortality. The aim of the study was to look at the association between statins and liver disease progression to cirrhosis, hepatocellular carcinoma, and death in patients with non-cirrhotic chronic liver disease using nationwide cohort with liver histopathology data. This was a nationwide retrospective cohort study based in Sweden. The authors used the epidemiology strengthened by histopathology reports in a Swedish cohort. They identified all adults with chronic liver disease who had an index liver biopsy performed between 1969 and 2017. They included patients with viral hepatitis, alcohol-related liver disease, autoimmune hepatitis, and non-alcoholic fatty liver disease. Statin use was identified from a prescribed drug register defined as prescription filled for at least 30 consecutive daily doses, and the statin users were matched to non-statin users with chronic liver disease in a 1-to-1 ratio, followed by propensity score matching. The primary outcome measure was the incidence and progression to severe liver disease, defined as composite of cirrhosis, hepatocellular carcinoma, and liver transplantation or liver-related mortality. They were able to identify 3,862 patients with chronic liver disease who used statin, and 3,862 patients who had chronic liver disease and identified as non-statin users. The majority of patients were men, 60.8% in both cohorts. The mean age, 62 years in both groups. When looking at the etiology of chronic liver disease, viral hepatitis accounted for 17.7%, alcohol-related disease accounted for 21.9%, autoimmune hepatitis 15.1%, and non-alcoholic fatty liver disease 45.3%. The duration of chronic liver disease was 12.5 years in the statin users, 12.4 years in the non-statin users. And when they looked at healthcare visits between 2 years and 6 months before start of follow-up evaluation, it was a mean of 5.3 years in statin users and 5.5 years in non-statin users. They then looked at the development of cirrhosis, hepatocellular carcinoma, and requirement for liver transplant. And they looked at the incidence rate per 1,000 person years. And the authors identified that statin use was associated with a decreased risk of developing severe liver disease, with incidence rate per 1,000 person years in statin users of 10.5 versus 18.1 in non-statin users. This results in a hazard ratio of 0.59, favoring statin use. Statin use was also associated with decreased risk of developing severe liver disease on subgroup analysis of the different etiology of chronic liver disease in alcohol-related liver disease, as you can see here, and non-alcoholic fatty liver disease. This is a summary of the main outcome measures. Again, when looking at the main composite outcome of cirrhosis, hepatocellular carcinoma, and liver-related mortality or liver transplantation. Again, hazard ratio was significantly lower in the statin users at 0.59 compared to non-statin users. And when they looked at the different subgroups of the main composite outcome, looking at cirrhosis, HCC, and liver-related mortality or liver transplant, again, the incidence rate of the main outcome measure of cirrhosis per 1,000 person years was significantly lower in statin user. Again, incidence of hepatocellular carcinoma was significantly lower, and liver-related mortality or liver transplantation was significantly lower in statin users. The main limitation of this cohort study is that the authors were unable to control for confounders, as there was no access to laboratory data, medication indications, or clinical notes. There were very few repeat liver biopsies, and therefore authors could not analyze changes in fibrosis over time according to statin use. The possibility of selection bias as authors may have missed individuals who were too sick to undergo liver biopsy or had contraindications to liver biopsies. The take-home point for this study is that in this large nationwide study with liver histopathology data shows an inverse association between statin use and non-cirrhotic individuals with chronic liver disease and development of severe liver disease. So this is the GI Journal Club recap. In a systematic review meta-analysis, authors were able to demonstrate clear clinical efficacy and similar clinical efficacy and better safety profile of Remimazolam compared to propofol for sedation for adults and GI endoscopy. Octreotide effectively reduced the transfusion requirement and requirement for endoscopic procedures in patients with angiodysplasia-related anemia, and therefore use of Octreotide in patients in whom endoscopic treatment is insufficient or unfeasible should be considered in these patients. The effect of add-on 30-second observation of the right-sided colon using TXI was non-inferior to MBI for polyp detection. And in a large nationwide study with liver histopathology data, there was an inverse association between statin use in non-cirrhotic individuals with chronic liver disease and development of severe liver disease. Thank you so much for joining me here in Orlando for the GI Journal Club. Our next monthly Orlando GI Journal Club is on May 1st, 2024, which is the first Wednesday of May. We have these every Wednesday. Not every Wednesday, the first Wednesday of every month. And I think there may have been some confusion with the old link for Zoom expiring. So please kindly use the new link that was sent out this week. That should be valid for the rest of the year. There's a chance we may have to renew the link on Zoom at the start of 2025. But if that's the case, we'll make sure we send an updated email with a new Zoom link. Thank you so much. It was so nice to see everyone. Please have a wonderful day, week, and month. See you in May.